This morning, I will be talking about essentials of what I called antimicrobial dosing. I think the title of this on schedule said antibiotic dosing, but a lot of these concepts are going to apply to drugs outside of antibiotics, so that's why I've named it thusly. So
this here, so it's out of your way, okay?
Oh,
yeah, there you go.
Cool. Thanks.
And perfect.
All right. So what we're going to review over the next hour-ish or so is to highlight the importance of why we should all understand dosing concepts. Obviously, you have the ID pharmacists at Tampa General, the VA, and Moffitt, but it doesn't mean that you all, as physicians, shouldn't understand these concepts and understand the thought going into dosing these drugs. Plus, it's not to say that somewhere that you practice in the future, you might not have access to an ID pharmacist. So that's why it's important for you guys to understand these concepts. We'll talk about pharmacokinetic and pharmacodynamic principles, and then we'll also discuss how PK/PD and then also patient-specific factors are going to influence the different dosing concepts that we'll talk about. All right, so why should we all care about dosing, not just your pharmacist? We want to improve patient outcomes. So if we're dosing these drugs appropriately from the start, we should decrease the need to prolong therapy. If we're dosing inappropriately upfront, that might cause us to need to extend our treatment outcome or treatment duration because patients aren't responding as quickly as we may want them to. Hopefully we can get them out of the ICU to the floor and then out of the hospital faster. And the sooner we get them out of the hospital, hopefully to their home, their outcomes should improve as well. We want to reduce adverse events. So again, we're appropriately dosing these drugs. We should be decreasing the risk for side effects, as well as minimizing the selection of drug resistance. If we're underdosing our antimicrobials, we're going to lead to potential selection of resistant strains. And then certainly if you don't want to hear from myself, Nick, or Mel, dosing up front is going to minimize some of those phone calls, text messages, secure chats at TGH. But certainly we're always here for you guys. We're not saying that we don't want to interact with you. All right, so you might be saying, can I just call my ID pharmacist if I have any questions? And yes, you can. Many large hospitals have ID trained pharmacists there for you. However, depending on the time of day, if you guys are on call, you get a page at midnight, you're not necessarily going to call one of us at midnight to run your dosing by us for the patient. Also, you might not have access to an ID trained pharmacist on the weekends, depending on the structure of the staffing at the different hospitals. The number and availability of pharmacists might be significantly lower or may not exist if you're in rural parts of the country or in critical access hospitals. We can't assume that we're going to be having those resources readily available. All right. Okay, and then if you're working in an outpatient-based environment, a clinic-based setup, you may not have access to an ID pharmacist at all. Certainly, we are more prevalent and commonly employed in the acute care hospital setting, not necessarily in the clinic setting. So that's another thing to keep in mind. All right, so these next several slides that I'm going to go into is going to be my suggestions as to how you think about drug dosing. Again, those parameters that I alluded to in the beginning on the initial slides. There are going to be different ways to think about these concepts, and you're going to hear different people talk about these concepts different ways. This is definitely a gray area in some aspects, so I'm just going to say my suggestions, but different people are going to talk about these things different ways, so don't think that this is a black and white situation. All right, so let's start off with comparing pharmacokinetics and pharmacodynamics. We talk about PK/PD a lot, but what are those concepts? So pharmacokinetics is referring to what the body does to a drug and how these drugs move throughout the body. So the four concepts that we commonly include under pharmacokinetics is the absorption, distribution, metabolism, and elimination of these drugs. And this is contrasted to pharmacodynamics, which is focusing on the relationship between the drug concentration in the body and then the pharmacologic or the toxologic effect of the drug. So we're seeing side effects, we're seeing, extreme levels of drugs, what's happening to the patient from that standpoint. William Craig published an article in CID in '98 and had this nice visual. So this is summarizing the relationship between kinetics and dynamics between our drugs when the drugs come into the body, get absorbed, distributed, metabolized, and eliminated, and then how we're seeing the effects of those drugs influence the patient. Breaking down our kinetic considerations a bit more when we talk about drug absorption. This is the drug's bioavailability, or how much drug is actually reaching the systemic circulation. So when you give a drug IV, some people say, oh, IV is better. IV drugs are being 100% bioavailable. However, it doesn't mean that we don't have oral drugs that are also very highly bioavailable. So definitely there's a big shift in the thought process that, hey, transitioning to highly bioavailable oral drugs is going to help patients minimize IV lines, get them out of the hospital faster, minimize those complications from IV lines. Now, yes, bioavailability of oral drugs is going to differ. Not all drugs are 100% bioavailable or highly bioavailable. I'll show you an image shortly that's going to compare and contrast the bioavailability of different drugs. That's something important to keep in mind. It's also important to know that just because a drug is highly bioavailable doesn't mean it's getting to the site of infection where you want the drug to be acting. So that's going to be something else that we talk about, but that's something important to keep in mind. Now, I don't know if anyone knows Paul Sachs or follows his blog. He has a really good commentary at this link talking about antibiotics that have very good oral bioavailability and how that is really influencing a lot of practice patterns from an ID standpoint. So I suggest you guys take a read at this blog post. It's not very long. He's a very entertaining writer as well, so it's enjoyable to read his stuff. But from that blog post, he has this image here. So towards the top, you have your highly bioavailable oral antimicrobials. This includes our quinolones, metronidazole, rifampin, some of our oral azoles. And as you go down the list, you do see that the bioavailability significantly drops for some of these drugs. It doesn't mean that there's not a role to be choosing these drugs that are lower in the table. It's just something that you need to be thinking about when you're treating certain infections. This is something that you are going to be considering. When we move on to distribution, what distribution is referring to is where drugs go into the body. Not all drugs are going to, cross the blood-brain barrier and go and treat CNS infections. Not all drugs are going to penetrate the urinary tract. But where do drugs go in the body? A concept that we as pharmacists think about is volume of distribution. What this means is the total amount of drug in the body related to the amount of volume in that same space at any given time. So we compare and contrast drugs that have high volumes of distribution versus low volumes of distribution. If you have a drug that has a high volume of distribution, it's going to go into the tissues more readily, versus those with low volumes of distribution are going to distribute a bit less to the tissues and stay more in the plasma space. So what else influences a drug's volume of distribution? If it's hydrophilic or lipophilic, is it going to go more into the water area of the body versus is it going to be more apt to penetrate to, fat heavy areas of the body, some of those tissues? The charge of the compound can influence where the drug distributes, the molecular weight and size. So very, very large, bulky molecules, bulky drugs are not going to penetrate readily into certain spaces of the body. Namely, you're thinking crossing that blood-brain barrier. Protein binding is something that we're going to talk about a little bit, and that's something that we can consider with certain antimicrobials. The presence or absence of inflammation, certainly as patients have a lot of inflammation, thinking about maybe some CNS infections, we give steroids. That's going to decrease inflammation, but does that also decrease the penetration of drugs across that blood-brain barrier? And then lastly, transport mechanisms. This can also influence where drugs may penetrate across different membranes more readily than others. So just applying these concepts of volume of distribution to scenarios that you guys run into on a regular basis. So the concentration of a drug is related by the amount of drug in a certain volume. Now, if you have a patient coming in, sepsis alert, sepsis response, you're going to give a lot of fluid. Maybe not you guys, but our critical care colleagues are going to be volume resuscitating them, 30 mils per kilo. So you can imagine a lot of fluid there. That's going to be increasing that presumed volume in the space where our drugs are going to go. Now, if we're trying to maintain a certain concentration of drug at that site, for beta-lactams, we don't think of a certain drug concentration, but for something like aminoglycosides, we're trying to hit that max concentration to be improving our efficacy. In order to maintain that concentration of drug, what we need to do is correspondingly increase our amount of drug that we're giving, that milligram or gram amount, so that we account for the fact that our volume has now increased and we want to maintain that concentration. So this is an example of how volume of distribution, fluid resuscitation is going to influence our dosing of drugs. Moving on to metabolism, this is how we break down compounds in order to move on to the elimination of compounds from the body. A lot of this is done in the liver, usually through cytochrome P450 enzymes. With that enzyme class, we run into a lot of drug interactions. We don't expect you guys to memorize drug interactions. Frankly, pharmacists don't memorize every single drug interaction that's out there. What's important to know is there are certain drugs that whenever you see them on a patient's profile, or if you're thinking about prescribing certain drugs, you should be running a drug interaction check or asking your pharmacist, hey, can we just double check that we don't have any relevant drug interactions that we need to worry about? A few of the drugs that you're always going to be thinking about this in are the ones that are in the table here. A few drugs that are pretty typical inducers that you're going to run into problems potentially with: rifampin, efavirenz, which we learned from Dr. Sherbuck yesterday isn't used as much in HIV regimens, but certainly is out there for patients who have had longstanding HIV and are on stable regimens. Carbamazepine and phenytoin, these drugs can cause some problems with some of our antimicrobials. And then inhibitors are azole antifungals, which again, the inhibition of the CYP enzymes is going to be different depending on the azole. There are some differences there, but those drugs are going to be inhibitors, as well as ritonavir, clarithromycin, and cimetidine. So you see some of these drugs just as examples. You should be thinking, hey, let me look at my drug interactions, and do I need to be thinking about anything ahead of time? Maybe it's a contraindication, we can't use these drugs. Maybe we have to dose adjust some other drugs. So good thing to keep on the radar. And then lastly, elimination. So this is how drug levels decrease and are eliminated or leave the body. Once we hit that peak plasma level at some concentration, drugs will decline at a certain rate. These rates can differ depending on the particular drug and if it's going via a renal route or not, if a patient has renal dysfunction. Now, these drugs can be eliminated via their metabolites or as unchanged drugs, so there's different ways that this can happen. And we will commonly be saying a phrase called the half-life of the drug. What that means is the amount of time for the concentration of drug to decrease in half and then decrease in half again. So that's something from a pharmacist standpoint that we're already always considering. This is a visual of what's happening. This is a generic concentration time curve. So again, you hit some maximum concentration, whatever that may be for the drug, and then it's going to eliminate from the body at a certain rate over a certain period of time. All right, so now that we have some of those kinetic parameters under our belt, what do we want to be thinking about when we consider drug dosing for our antimicrobials? So we want to think about pharmacokinetic and different pharmacodynamic principles. We want to be thinking about the infection and where the infection is. So where do we need that drug to penetrate to in the body? What organism we're thinking that we're either suspecting is causing the infection, maybe based on a history or based on a presentation, or if we have cultures, what do we know we're going to be targeting? Thinking about the renal and hepatic function of the patient. If patient has, end-stage renal disease, we're not going to dose cefepime the same way as if someone had normal kidney function. Thinking about patient factors, so patient's body weight is going to influence how much drug we give depending on where we want it to go, as well as different drugs that are weight-based are going to be dosed either by actual body weight, adjusted body weight, or ideal body weight. And that's certainly going to influence the dosing a lot if we have an obese patient. If we have a critically ill patient also, we want to make sure that we're taking their status of their illness into effect. And I'll talk about how this is something that we want to keep in mind, especially early in that critical illness in a few slides. So now thinking about all of these different factors, and I know it's a lot, how can we optimize these different factors when dosing drugs for our patient? Okay, so you guys have probably seen some representation of this. So this is showing, again, concentration time curves, time on the x-axis, concentration on the y-axis. We have some targeted MIC. This is not meant to represent any specific organism or MIC, but at some concentration, we have the MIC for that targeted organism. So as we give our drug and have it decay over time, certain drugs are going to be optimized based on different parameters. So we either have Tmax over MIC, so we want to be dosing these drugs multiple times a day, usually to keep that concentration over the MIC as long as possible. Maybe it's a drug where we want to hit that maximum concentration and optimize that. We don't really care how long it's over the MIC for. Or more drugs are actually being reclassified into exposure, meaning AUC over MIC. Certainly Vancomycin is a big one that we think about there based on the new guidelines. So this is what I just said. This visual is showing how some of our antibiotics are classified into these three categories. So our prototypical time over MIC drugs are our beta-lactams. Certainly that includes penicillin, cephalosporins, carbapenems, as well as our sole monobactam drug, aztreonam. Our Cmax over MIC drugs, we do have our aminoglycosides. We can take advantage of extended interval dosing to optimize that Cmax for our aminoglycosides. And we also have fluoroquinolones, which can be considered Cmax over MIC drugs, but then also there's more schools of thought that maybe this is also a drug class that's exposure driven. And then vancomycin, based on the new 2020 guidelines, is more of an exposure drug. We're getting away from trough levels and dosing based on AUC. So now let's talk about these three different classes and how we can be optimizing the drug dosing based on if they're time, concentration, or exposure-driven drugs. So for our time over MIC drugs, our beta-lactams, there's different administration strategies to optimize the PK/PD of those drugs. You've likely heard of extended infusion beta-lactams as well as continuous infusion beta-lactams. The idea here is, especially when you get more resistant organisms and that MIC is increasing, you can imagine visually that we're going to need to do something to keep the drug concentration over that MIC for as long as possible. That's where these two infusion strategies really optimize the outcomes based on beta-lactams. So this visual is showing the different dosing strategies. So your standard intermittent infusion here is shown in the green bar here. So you have a 30-minute infusion. You can see that you have a decent amount of the dosing interval that's over that MIC, but there is a period of time where your drug concentration goes below that dotted gray line of the MIC. In order to keep more of our drug concentration over that MIC, we can do an extended infusion, which is shown in the blue line here. So we would give an intermittent infusion of a loading dose up front. We're not going to infuse prolonged that initial dose. But then as we give our subsequent doses, each infusion is going to be over 3 to 4 hours. You can see that that blue line never actually comes down to the MIC. So we're truly optimizing the time over the MIC with that dosing strategy. And then finally, the red line there is our continuous infusion. You also see there that our drug concentration never comes below the MIC. So these two strategies are able to optimize our PK/PD for our beta-lactams. I will say in the hospital setting, you're more likely to see the extended infusion dosing strategy. You're not really going to see continuous infusion strategies. However, that's something that's going to be very important when transitioning a patient home. The caveat here is not all beta-lactams are stable enough at room temperature for 24 hours to take advantage of continuous infusion strategies. So you always have to be checking, is my drug stable? Is the outpatient home health pharmacy going to be able to give the patient a continuous infusion of this drug? One drug that we usually want to do this with, but we're not able to due to stability, is Unison. But you can take advantage of this with Piptazo and Cefepime commonly. All right, so for our concentration, max concentration driven drugs are aminoglycosides. This is where we take advantage of the extended infusion protocols that are out there. This also takes advantage of the concept of a post-antibiotic effect that is in place with aminoglycosides. So we don't have to keep the concentration of aminoglycosides over the MIC of the drug like we do with beta-lactams. We actually want to try to eliminate the drug out as quickly as possible so that we don't have prolonged concentrations around that can lead to side effects such as ototoxicity, vestibular toxicity, which are going to cause the patient a lot of problems. This visual here is showing those two different dosing regimens. So again, concentration time curve. The solid line is going to show you the intermittent infusions, which are given every 8 hours. You can see that we're really not hitting a very high peak, and we have to be dosing several times a day. Whereas the dotted line there, which is the extended interval dose, we get a much higher peak. So optimizing the outcome that's going to drive the efficacy of aminoglycosides. And then we decay out at a certain rate. And it's okay that we get our concentration below the MIC because, again, we do have the post-antibiotic effect for our aminoglycosides. And then the drug that we're dosing very regularly in the hospital setting, you guys all are prescribing, is Vancomycin. Again, in 2020, we did have a change in guidelines that said our previous thought, where we have to keep troughs between 15 and 20 as a surrogate for our AUC range of 400 to 600, is actually incorrect. I will thank Nick. I took this image from one of his previous presentations, but this is showing a graphical representation of data points of the Vanco trough and its corresponding AUC for thousands of patients. What you can see is that these data points are all over the place. The vertical red lines are showing that general trough range of 10 to 20. That's certainly a large range. And if we were targeting MRSA treatment, we would be focusing on what we thought our trough range should be, is 15 to 20. Now, the horizontal green lines is that AUC range of 400 to 600. Now, if you can imagine, we have right from about here to about here is where we thought that troughs would correspond to the AUC that we're trying to target. And you can see that that's very incorrect. Now, if you are also looking at this trough range from 15 to 20, a lot of these AUCs are actually way above that threshold of 600. And this is where we know that we're going to more likely see nephrotoxicity and side effects. And that's what we were seeing in publications and reports, that even with these therapeutic troughs of 15 to 20, patients were still at risk and still developing side effects from a renal standpoint. So that's okay. So we knew that AUC dosing was coming. It did come in 2020. So it's not coming, it's here. And these guidelines said that we're going to transition to AUC-based dosing. However, the data that's out there to support AUC dosing is almost exclusively in invasive MRSA cases right now. So that's what the guidelines focused on. They didn't say that you can't use AUC dosing outside of MRSA. It's just saying that where the data exists right now is in that space. So they can't really comment as to the role of AUC dosing outside of that. They also say that you should be obtaining therapeutic AUCs within the initial 24 to 48 hours of starting vancomycin, which, thinking about trough-based dosing, is much sooner than we were able to do with trough-based. They also say that you can do AUC dosing in two different ways, either by a Bayesian approach using historic modeling in order to model what your current patient's kinetics and elimination of Vanco look like, or you can do a more math-based approach using two-level kinetic calculations. So what we have done at Tampa General Hospital, Here it is. I can't speak to what the VA and Moffitt are doing, so certainly speaking with the pharmacist there to understand their dosing strategies if they've gone to AUC dosing or are currently planning on doing so. At Tampa General, we have gone to AUC dosing. We do AUC dosing for all Vanco patients. We don't just do it for MRSA patients. Our thought is if it's good enough for MRSA, it's good enough for strep, it's good enough for enterococcus. The only places that we don't do AUC dosing is for CNS infections because the data there is not strong to say that the range of 400 to 600 is going to be effective for CNS infections. And then also if someone has changing renal function, we don't do it in that setting because these models aren't as accurate. But we use a system called DoseMeRx. This is a visual of what the pharmacist sees on their side. You all as physicians are not able to see this, also because you're not doing the AUC dosing. But this is a system that we use that's incorporated into Epic, so it's not a side program. It's something right in our EMR, which allows for a more simplified workflow for our pharmacist. The alternative dosing strategy is using two-level kinetics, doing a lot of math with Linglog, trap modeling and concepts. If you guys ever want to take this on and be doing kinetic calculations instead of us doing the Bayesian approach in DoseMe, please let us know. But this is the other way that people would be dosing things outside of integrated software within their EMR. Okay, so just to break up some of the concepts we've already talked about, I'm going to have us think through a case right now. So we have a 30-year-old female who is admitted with E. coli bacteremia from a urinary source. It's confirmed that the source is pyelonephritis, and the E. coli isolate is pan-susceptible to everything that's on your reporting card. The patient is afebrile, their white count is 5.6, they have a normal serum creatinine. This is their baseline serum creatinine. They're not on any renal replacement therapy to develop this lab value. They have a regular diet. They don't have any significant concomitant meds that you would worry about drug interactions. And the medical team contacts you because they want to send the patient out on oral ciprofloxacin to complete her course. So which of the following responses would you say is most accurate? Is it A, pyelonephritis should never be treated with oral antibiotics? I like the no. B, ciprofloxacin does not cover E. coli, so this would not be an appropriate choice. C, ciprofloxacin has good bioavailability, penetrates the kidney well, so this would be a reasonable option. Or D, cipro only comes IV, so the patient must finish their course with IV ciprofloxacin.
C.
All right, good job. Probably didn't even need my slides beforehand to know that that was the right answer, but yeah, so C was the correct answer. Again, the reasons why the other choices are incorrect for those other learners in the room. Pyelo is definitely an infection where we can use oral antibiotics. The guidelines suggest oral antibiotics are reasonable. Now, you need to pick an oral antibiotic that's susceptible to the organism, but quinolones are a drug class that are very highly bioavailable, so great choice to be picking to send the patient home. Cipro does cover E. coli. Now, if it's resistant, that's a different story. But at baseline, wild-type E. coli, certainly quinolones can cover that. And then choice D, Cipro does come IV. So that's just incorrect because it's available as an oral tablet. Okay. Albumin and antibiotics, I'm just going to talk about how this influences, drug choice, maybe drug dosing. I'm not going to take an opinion on this debate, though, but guaranteed in fellowship, you're going to talk about antibiotics and the impact of albumin. So albumin is a very important protein. It does bind our antibiotics. So there's going to be drugs that are more protein bound and less protein bound. Now, only non-protein bound drug that's in the plasma can penetrate and equilibrate with the extravascular space is going to be able to penetrate to our site of infection to exert its effect. So if you have a septic patient, you have increased capillary permeability, you're going to have potentially a decrease in that protein, in that albumin. So this is going to result in an increased amount of unbound drug because protein, albumin, is not there to bind to it. And the concern there is, especially in a septic patient, maybe you have some augmented renal clearance, different changes going on. You might see an increased clearance of that free drug, so you're not going to have as much drug around in order to exert its effects and be treating the patient's presumed or known infection. I will say, related to this concept, again, the example that I gave as to what's going on here is in a critically ill patient, is in someone that has a lot of dynamic changes going on. It's not in a stable patient, a floor patient, someone who is not going through these changes. So definitely your patient population, this concept may be a little different as you think about applying it. But the drugs that have been part of a lot of discussion, a lot of debate in the last several years are ceftriaxone and ertapenem. So these are the drugs where this concept is probably going to apply to, and you need to think about it more so than some of our other antimicrobials. But you're definitely going to engage in good discussion with your attendings and your teams on this related to ceftriaxone and ertapenem throughout your fellowship. So I would encourage you all to read the literature, see what's out there on this topic, what those trials are looking like. But this is something you're going to encounter that could be a clinical conundrum in certain situations. Thinking about where we want our drug to get to, we need to be thinking about what the site of infection is. So where did this infection originate? Where do we need our drug to get to? Drugs that penetrate into the urine, in my opinion, you don't need to be maxing out that peak. You don't need to be shooting for aminoglycoside peaks of 12 to 15 when aminoglycosides at baseline concentrate in the urine so well. So when you look at different dosing algorithms, different dosing guidelines, you'll see that the peak targets for aminoglycosides, Gentin-Topra, for example, here, are going to be lower than for a systemic infection. And that's just because these drugs concentrate into that area of the body so well that you don't need to be potentially putting your patient at risk for side effects from giving them too much of an aminoglycoside dose. Additionally, most antimicrobials do not penetrate the blood-brain barrier into the CNS 100%. There's some drugs that certainly penetrate this area of the body more so than others. But for the most part, whatever drug you pick, you're going to need to be maximizing your doses to penetrate into the CNS for known or suspected infections. And then for some drugs, as you decrease that inflammation, that might also be influencing the fact that you need to be maximizing those doses for these infections. So consider what drug you're using, where you want it to get to, and if you need to be increasing the doses to effectively treat your infection. Thinking about the organism of interest, if you have not heard about CLSI, it does exist, and it's where we get our MIC breakpoints, what tells us what's susceptible, intermediate, resistant. This is for MICs as well as Kirby-Bauer zone diameters. The resource here at the link is free. Now they ask you to put in your email address. They don't, say, oh, you have to pay for a subscription or anything, but you do have to put in your email address to get access to the site, but it gives you the reference that the lab is using. And instead of having to ask someone, oh, what's the breakpoint for this organism in this drug, you guys can be looking this up on your own. I would encourage you to bookmark the site because you're going to be using it very frequently, not just in fellowship, but when you get out into your clinical practice. So for example, for Pseudomonas aeruginosa, the breakpoint MIC is less than or equal to 8 for a drug like cefepime. And CLSI also tells you what drug dosing this breakpoint is based on. So this breakpoint is based on a cefepime dosing of either 1 gram Q8 or 2 grams Q12. The other important thing to note is that breakpoints for drugs are going to be different for each bug. So you can't look at a listing of MICs and say, oh, the lowest is the best, because those MICs and those ranges are going to be different for every single drug for a particular bug. And they're also going to differ for drugs depending on the bug that you're looking at. So the lowest MIC is not necessarily the best. It might be the one that you choose, but that's not the only thing that we're looking at here. So if you are encountering a patient who has an infection caused by an organism with a higher MIC, a few things that we can think about in terms of what dosing strategy we may pick. There's a ton of publications out there using Monte Carlo or modeling simulations, and based on a certain dosing schematic, based on a certain infusion, if it's intermittent or extended infusion for beta-lactams, as well as a patient's renal function, how would we anticipate the amount of drug that's getting over or, hitting our target attainment to be? Ideally, we would like it to be over 90%, but that's something also that we can look into. Now, if that's a little too high level for you, you say, hey, that's probably more of a pharmacist looking at. The IDSA expert guidance that they've come out with, several iterations over the last few years. The most recent one was actually published a week or two ago. They also will give you dosing recommendations if you're running into a drug-resistant or difficult to treat Pseudomonas, an ESBL isolate, maybe a carbapenem-resistant Enterobacterales isolate. So that's another good reference that I would encourage you guys to look at, to read, to bookmark in your computers. All right, last year, one of the fellows had wanted to know a little bit more about daptomycin, MICs, and dosing. And I do think it's still an important concept to bring up because the dosing and the MIC interpretations and breakpoints are going to be different for dapto, whether you're talking about E. faecium or other enterococcal species. The reason why they've had changes in the breakpoints and then drug dosing over the last few years is shown here. The orange bars are E. faecium. You can see that those MICs tend to be higher than E. faecalis MICs. And we've also been seeing over the years that the trend in E. faecium MICs is going up to the point that even at Tampa General, we're maxing out dapto dosing for E. faecium isolates because we tend to see those higher those higher MICs, some even starting at a breakpoint of 4. So it is concerning that if we underdose those patients initially, we're going to have poor outcomes with these E. faecium invasive infections. This is a screenshot of what you'll see in CLSI related to dapto comments for the different enterococcal species. For E. faecium, the breakpoint is always susceptible dose dependent, and the breakpoint is 4, versus you'll see that for other enterococcal species, the susceptible breakpoint is 2, intermediate is 4, and then resistant is 8 or greater. So if you're seeing different breakpoints for the enterococcal species, this is why. And then also the dosing is going to be different. So from CLSI, the susceptible dose-dependent dosing or breakpoint is based on dosing of 8 to 12 mg per kg per day. So if you have a patient, invasive enterococcal faecium infection, you're waiting on your MICs, you may want to be dosing at that higher end of the range here because more than likely, especially if you're seeing trends in higher MICs at your institution, you're probably going to be seeing an MIC of 2, 3, or 4 off the bat without even any dapto exposure. Dapto dosing for other enterococcal species is based on a dosing of 6 mg per kg Q24. You'll see people even start a bit higher, maybe at 8 or 10 mg per kg for other enterococcal species, but this is at least what's listed in CLSI and where they get their breakpoint data from. You might ask why this is happening, and it's likely because the initial dosing recommendations on dapto for invasive VRE infections was inadequate. We saw changes in these MICs, and now we do have to respond to what we're seeing clinically causing infections in patients. And we are knowing that we have to increase our dose to hit those PD targets for these VRE infections. So something you guys will definitely see at Tampa General, I'm sure at Moffitt, and presumably the VA also encounters these patients. All right. So another patient case, we do have a 51-year-old man who's admitted with Pseudomonas aeruginosa bacteremia. These are some of his characteristics: 90 kilos, 6 foot, no drug allergies, an elevated white count, but a normal serum creatinine. So of note, your hospital does not have any of the newer beta-lactam antibiotics. Maybe you can get it non-formulary, but at the current time, you don't have any access to those newer BLIs. And this is what your susceptibility profile looks like. So not very friendly. But what do people think here? Which drug would you choose? And then would you modify the standard administration of the drug, considering some concepts that we've talked about already? No bueno.
I think you go straight to meropenem if it's sensitive to it.
Now, while I don't have it up here, 2 is the breakpoint for meropenem for Pseudomonas aeruginosa. Yep, exactly. So I would max out the dosing. Their kidneys are normal, so max dose of 2 grams Q8 of meropenem, and I would extend the infusion. So each of those doses, aside from the first one, I would do at least a 3-hour infusion. Now, again, you can have your lab run the newer drugs, see if we have an option. Zerbaxa, hopefully is going to be something that we can pick eventually, but at least up front, since we don't have access to those other drugs, I agree. High dose extended infusion to optimize our kinetics and dynamics of that drug. Any questions on that? Okay. This is probably simpler than what you guys will run into, but at least hitting home what we've talked about. Yeah.
So the MICs on it's not like a local based on resistance locally.
No, yeah, it's nationally. Okay. Certainly we think about many of our beta-lactams, we think about some of our other drugs, that renal adjustments are going to be necessary based on a patient's level of renal dysfunction, because the kidney is going to be a major route of elimination for many of our antimicrobials. Now, when these drugs get approved by FDA and go through the regulatory pathway of approval, they're assuming that a patient has stable CKD. They're not thinking about these dynamic changes. They're not thinking about a septic patient. They're not thinking about someone coming in into your ICU and getting all of this volume resuscitation. So thinking about what's happening in our patients that we're seeing at the bedside every day, if we inappropriately dose reduce these drugs up front in a septic patient who has transient changes in renal function. For many patients who have stable normal renal function at baseline, you fluid resuscitate them. If they come in with an AKI, their creatinine, their renal function, their urine output is going to be improving. However, if we're reducing those doses up front based on what the computer is telling us their kidneys are functioning at, we're going to have low drug concentration. Then potentially, as their kidney function improves, we're going to be slow to respond to that. So the patient is going to have a slower clinical response. And then potentially we're going to increase resistance of the bugs that are causing the infection, or the patient is just going to have poor outcomes. It's notable that for some of our newer BLI combos that have been approved, they do have this warning and precaution section in their package insert, basically saying that in clinical trials, they saw a decreased efficacy of the drug in these patients who had moderate levels of renal dysfunction. Creatinine clearances were in the 30 to 50 range, probably because when they came into a hospital setting, came in to receive these drugs, they had some presumed decrease in renal function. We went and dose adjusted them based on what the computer told us. However, as we're volume resuscitating them, as their kidney function is improving, they're having too low of a drug concentration in their system to effectively treat their infection. So what you'll hear from me, what you'll hear from my ID PharmD colleagues, and probably the same at the VA and Moffitt, that initial 24 hours, you need to be at least pushing your drug dosing a bit more in those critically ill septic patients. That initial 24 or 48-hour window is crucial for their outcomes. You can always back down on the dosing of especially beta-lactam antibiotics, but you can't really catch up once you underdose them up front. So this is something that we definitely want to keep in mind. Now, if someone goes to CRT or some sort of renal replacement therapy, we can certainly dose adjust in that setting, but extra amount of beta-lactam in the first 24 hours in a critically ill septic patient is not going to do anything harmful to them, in my opinion. Leading into renal replacement therapy. So this is a methodology for removing toxins, waste, and fluid from the body. We're all familiar with it. It can be either intermittent or continuous. You can have hemodialysis, peritoneal dialysis, or some form of CRRT. However, for CRRT, there's going to be a number of different factors that go into these modalities to remove more solutes, more fluids, and different hospitals are going to have different CRRT modalities, different CRRT machines. So the type of machinery and settings that we use at Tampa General is not necessarily the same as the VA, not the same as Moffitt, not the same as other hospitals that you're going to be working at. So the dosing of drugs across these different circuits is not going to be the same. I definitely would recommend that you speak with your pharmacist at the hospital where you are working to see if they have a protocol as to how the standard dosing of different drugs is done based on CRRT circuits that are there. Also at Tampa General, we have what's called PERT, so prolonged intermittent renal replacement therapy, which is kind of a hybrid between hemodialysis and CRRT. So that adds another level of complexity. But if you look at this Trotman article from CID from 2005, you'll see this reference. I don't know if Up to Date would have something similar to this, but basically these modalities here are not going to be exactly what you're going to encounter at the hospitals and institutions you work at. So it's best to look at what their dosing protocols are, because that's going to be more accurate for the RRT machines that you're going to encounter that patients are going to be using there. So other patient factors that are going to go into our drug dosing: body weight. We're not going to be dosing an underweight patient the same as an obese patient. So in some of our obese patients, we may need to increase the drug dosing that we give, especially our beta-lactams. More adipose tissue, more body weight, that's where our drugs can certainly penetrate to. So we may need to increase our doses to maintain the same drug concentration. Also for drugs that are weight-based, so think of things like ganciclovir, amphotericin, maybe voriconazole IV. These are going to be based on different weights. Some drugs are going to be ideal body weight, some adjusted body weight, some actual body weight. So whenever you're getting an order to be putting in weight-based dosing, make sure you're thinking about which body weight to choose. And this also is probably a great opportunity to call up your pharmacist and say, hey, this drug dosing is based on which weight, because different drugs are going to use different weights. Critical illness, I've mentioned this several times this morning. Renal function and dysfunction are going to be important for renal adjustments. We don't want to be underdosing in that early time frame of critical illness. Fluid resuscitation is going to impact our volume distribution and our drug dosing. And then augmented renal clearance, which, definitely is a phenomenon we see. How do we actually know that it's going on? Great question. But that's going to increase the clearance of our renally eliminated drugs. So that also may influence us to push drug dosing. Some of the newer beta-lactams, cefidoracol, for example, actually has drug dosing in their package insert for augmented renal clearance. So we might be seeing that concept also play into drug dosing, where actual recommendations will be coming forth with some of our newer drugs that get approved. ECMO is a big thing. We encountered a patient on ECMO this past year where we actually sent out drug levels because the ECMO circuit itself can sequester drugs in it so that the effective drug the patient sees that's going to be treating their infection is going to be lower than we anticipate. We may have to send out drug levels in certain situations. And then based on that drug level, you might actually be increasing the dose way past what you see in clinical practice standardly or what the package insert says. But definitely be thinking about the drug dosing that you're picking in ECMO patients, because that's definitely something that is a problem and we need to be thinking about more. All right. So in conclusion, drug dosing, yes. It is something pharmacists do. We're the drug experts, but I would argue that these dosing concepts are things that all of you as ID physicians should be understanding and knowing. Maybe not to the same extent that a pharmacist does, but they're still important for what you guys do for patient care. Pharmacokinetics and pharmacodynamics drives the patterns of dosing of our antimicrobials. And now pharmacists are always available for you, especially your ID pharmacist colleagues. During your training years, during these years of fellowship, take advantage of the resources you have to be learning these concepts more, because there's no guarantee wherever you go to practice in the future that you're going to have these resources available. So good to learn these concepts and some of these situations as you have the resources around. Now, I am early. I know Dr. Kim is here, I think, but I did take the liberty upon myself to add in some bonus content. It doesn't have to do with drug dosing, but I didn't see in any of the topics, at least in the next few months, that you guys had anything on antibiotic allergies. It's something huge that the stewardship team at Tampa General has been focusing on for the last 1.5 to 2 years. I'm sure our VA and Moffitt colleagues are doing the same thing. And because we're seeing so many patients come in that have penicillin allergies, we don't know what the reaction is. They avoid beta-lactams because they say penicillin allergy, we can't give anything in the beta-lactam class. That causes problems. So I would argue, besides pharmacists, you all on the front lines are huge advocates to be clarifying allergies, challenging allergies, and disseminating information as to these misnomers related to antibiotic allergies. So just going to take a few slides to go over some concepts that you guys may know already, but hopefully some things that you guys can learn and start implementing in your practice. So a few stats on penicillin allergies. We know, based on a lot of data, cefazolin and nafcillin or oxacillin are our superior agents for infections caused by MSSA over vancomycin. So while people might say, oh, they have a penicillin allergy, I'll just do vanco, we should be saying, no, let's clarify that allergy. Let's challenge that allergy, because our mortality, our outcome data is superior with things like cefazolin and our anti-staph penicillins. Additionally, penicillin and ceftriaxone are drugs of choice, respectively, for syphilis and gonorrhea infections. With the increasing resistance of gonorrhea infections, we don't want to be using substandard regimens. And then syphilis, we might be getting to the end of our IM penicillin shortage, and we want to be giving penicillin whenever possible. Even if someone has a labeled allergy, again, we can desensitize, we can challenge. Let's not give them a substandard regimen. And then from a surgical prophylaxis standpoint, when we're using non-beta-lactam drugs, we're increasing the risk that these patients are going to develop potential surgical site infections, which is a ding on the surgeon, a ding on the hospital, and something that we'd like to avoid. Tons of patients have antibiotic allergies. The last estimate that's out there is over 30 million Americans have a documented penicillin allergy. This is like a huge range of, oh, my mom told me I was allergic, to, oh, my father's allergic, so I must be allergic, to true allergies. But it is a big problem because the majority of these patients can still tolerate a drug in the beta-lactam class. The most common reaction that we see reported is a benign rash. We all have likely encountered this in clinical practice. And for some of our older patients, they have this allergy from when they were 5, 6, 7 years old. If they're 45, 50 years old, it's very possible they outgrew this reaction, because these true IgE-mediated reactions do wane over time. So even if someone had the reaction 25 years ago, it's quite possible they can receive a drug in the beta-lactam class and be just fine. This shouldn't be a reason why we avoid beta-lactam antibiotics. So what does it mean when a patient is labeled with a penicillin or a beta-lactam allergy? Well, it means that we're using a lot of second-line non-beta-lactam antibiotics, mainly vancomycin, aztreonam, fluoroquinolones, and clindamycin. This is both in the surgical prophylaxis setting, but then also clinically to treat infections. What might be surprising is that, and all of this is referenced in these citations, I didn't make up this data, it's been shown in the literature that these patients with labeled penicillin and beta-lactam allergies receiving alternative antibiotics have a 14% increased risk of death, more than a 3-fold increased risk of an adverse outcome, a 26% increased risk of C. diff, and we always want to avoid C. diff if we can for a patient to develop that. Almost a 50% increased risk for surgical site infections, and then our drug costs during hospitalization can be over $600 more. So definitely a lot of reasons why we want to clarify and challenge these allergies. A big question that people have in the surgical prophylaxis setting is, oh, well, I can't use cefazolin, which is the #1 drug that's recommended in the guidelines and that most people receive. These are just a few screenshots. It's definitely not inclusive because there's tons of publications out there. But in the last, I would say 5 to 7 years, maybe even within the last 10 years, more and more publications showing that these patients with penicillin and beta-lactam allergies can successfully get cefazolin, have no adverse reactions, and especially in the setting of surgical site infections, when we can use cefazolin, we're going to be decreasing that risk for SSIs. So it's going to really be positively impacting the patient. Now, you might be wondering, well, how do I know which beta-lactam is safe in a patient that has a penicillin or a cephalosporin allergy? And all of the risk of allergies and cross-reactivity of allergies is based on the similarity of the side chain of the structure. So first-generation oral cephalosporins have a estimated 2 to 8% risk for cross-reactivity. This is likely overestimated because it's based on historical data, but the cross-reactivity between amoxicillin and ampicillin is most with our first-generation cephalosporins, cephalexin, and cefadroxil because of the similarity of the side chain. It's important to note that I didn't say the similarity existed for cefazolin. This is a cephalosporin in the first-generation class that's structurally dissimilar to any other beta-lactam agent, so that's why we should feel safe giving it even in a patient that has a beta-lactam allergy. And I'll show you a nice chart on the next slide that demonstrates this as well. As we go further into the different generations of cephalosporins, you'll see that that potential cross-reactivity risk decreases almost at its non-existent in our 4th, 5th, and later generation cephalosporins because those structures are so dissimilar. Also important to note that the cross-reactivity between penicillins and carbapenems is less than 1%. It doesn't mean that we give everyone carbapenems, but that is a safe drug class to use. And then the cross-reactivity between penicillins and aztreonam is non-existent because those side chains are dissimilar. I took this from one of Mel's presentations. So Mel, thank you for this visual. But this is a nice chart showing most of our beta-lactams. It's not all inclusive because we are having newer and newer beta-lactams approved all the time. But this is a good smattering of drugs that you commonly encounter where it's the same drugs on the top horizontal row as well as the leftmost vertical row. The orange boxes with the X is indicating those drugs that have the same R1 or R2 side chain. And then the yellow asterisk boxes are those with similar R1 or R2 side chains. So you can use this table, find which drug they have an allergy to, and then cross-link it with which drug you want to give them. And you're going to see if it's, gray or white, hey, we don't have any concerns. If it's yellow, there's going to be some similarity there. If it's an orange X, that's where we're going to have the same side chain. So that can also influence you to say, hey, this drug combo looks pretty good based on their allergy, or this one isn't going to be as safe. So dissimilar side chains are going to have no cross-reactivity risk. However, we can't apply this cross-reactivity risk to those reactions that are non-immune mediated. This is just going to be for our IgE-mediated reactions that we see with our allergies.
Could you slide, does that the beta-lactam allergy also apply to like anaphylaxis?
Yes. Mm-hmm. Yeah, so that's going to be an IgE-mediated reaction. That's going to be what we're talking about here, yeah. So as I'm talking about cefazolin, you'll see here, if you look at the vertical or horizontal rows or columns for cefazolin, no similarities here. No yellow boxes, no orange boxes. So again, this is also telling you, influencing you, you don't have to be avoiding cefazolin. Someone with penicillin allergy, it might seem scary, but then go back to one of those initial slides I mentioned, MSSA, superior treatment with cefazolin or anti-staph penicillins. We don't want to just be giving Vanco because it's easy. We want to be giving the best drug for our patients. We also have colleagues in the allergy immunology space who have been doing a lot of work to try to also combat the misnomers with antibiotic allergies. In 2022, both the American Academy of Allergy and Immunology, as well as the American College of Allergy, Asthma, and Immunology came out with relevant recommendations from this joint task force related to the cross-reactivity of beta-lactam antibiotics and the influence of allergies. So a few things that came out from this paper. I encourage you guys to look at it, though it's very long, so make sure you have some time to read it. First, they suggest that for patients with a history of anaphylaxis to a penicillin, that a structurally dissimilar R1 side chain cephalosporin can be given without having to do extra testing or taking additional precautions. That they suggest patients with a history of an unverified non-anaphylactic penicillin allergy, you can safely give a cephalosporin without having to do extra testing. And then lastly, patients with a history of an unverified non-anaphylactic cephalosporin allergy, you can also give a penicillin without additional testing. So it doesn't mean that these patients have to be desensitized. They technically don't have to be challenged. They don't have to have a penicillin skin test. All based on the similarity of the structure of the side chains of the drugs, based on the allergy and what you want to give. This is huge. We've been promoting this information from this joint recommendation to anyone that will listen to us at Tampa General. But I think these are very important concepts and things for you all to know because you're going to encounter these patients. We need to be sending the right message that we need to be challenging these allergies. If you talk to a patient and get an allergy history, document in the chart. It doesn't just mean document it in your note, document in the allergy field in the EMR, because that's going to be something across encounters that people are going to see. And also, if you find out that the allergy is bogus, it's false, it shouldn't be on the chart, I encourage you guys to confirm with the patient that it can be taken off the chart and take that off, because that's going to be something that's going to be labeled and definitely going to influence prescribing outside of people like y'all that know the best drug to give. It's going to, hey, when you get that warning in Epic, that really influences practice. So if we can minimize those warnings for allergies that aren't appropriate and aren't true, let's take them out. Okay, that's all I have. I'm an Odell Beckham fan, so that's why I put him up here, but I talked about a lot of stuff over the last hour and 5 minutes. Are there any questions